Rajeshwari Govindraj, and today we will be going over the quality improvement project that I did for my MHA practicum. Um, and we will go over the practicum site, the project charter, the DMAC approach, current state process, data analysis, root cause identification, proposed recommendations, and finally reflection and readiness for my next steps. So this quality improvement project I did at the University of Illinois College of Medicine, Peoria, at a pediatrics outpatient clinic, which includes the specialties of primary pediatrics, pediatric infectious diseases, pediatric gynecology, and genetics. To begin with, I started working on the project charter and developed a project charter, which I took it to the team for their input. I incorporated those inputs and obtained final approval. So the project charter that I developed includes the problem statement. It defines the goal statement, scope, objectives, stakeholders, key metrics, approach for the project, the data sources, and the timeline. So one of the main issues the clinic was facing was to increase the number of patients seen in the clinic per day. So our main goal was to enhance the patient throughput in the clinic, as well as enhance the existing process without compromising the quality of care delivered to the patients. The scope extended to all the 4 specialties of the clinic, which is the primary peds infectious disease, peds gynecology, and genetics. Our main objectives focused on studying the existing process, conducting a comprehensive analysis of the current process, and analyzing the data to identify any critical bottlenecks, to identify the root causes of the challenges, and to provide targeted recommendations to address those challenges and optimize the workflows and processes to enhance the clinic's patient capacity as well as patient satisfaction. One of the main objectives was to gather the voice of customer inputs, not just the patients, but also the staff members and the faculty members who've been working for these patients. The stakeholders included the leadership team, the administrative team, the entire clinic team, which includes the clinic managers, the providers, the nurses, the staff members working there, patients and families, and the IT team. The key metrics focused on the most important steps of the process from patient arrival to the patient checkout, which includes the check-in, rooming, as well as the consultation. So we focused on analyzing the check-in wait time, the check-in duration, the rooming wait time, the rooming duration, the wait time to see a consultant once the rooming is completed, and the duration of time the consultant spends with the patient. And after the consultants exit from the room, what is the amount of time the patient still spends in the room? Along with that, we also will be looking into the slot utilization rates, like how much of slots available have been booked, and the no-show rates, the cancellation rates, and the completed appointment rates, as well as the patient satisfaction metrics obtained via the patient surveys or the feedbacks. And the approach I've taken for this quality improvement project is the Six Sigma approach. And the majority of the data was obtained by in-person manual observation and documentation in the clinic. And we also obtained certain data from the electronic health record and, of course, feedback from patients, from staff, providers, as well as the nurses. The timeline determined for the project is 12 to 16 weeks. However, we went over by about 2 to 4 weeks because of clinic closure for the holidays, for the Christmas season. So this is the project charter. This is the project timeline where the green ones indicate the timeline when the specific tasks were completed. The gray ones are the tasks which are still under consideration with the upper management because they're considering what recommendations can be put into implementation. So that discussions are with the upper management and still awaiting final decisions. So in the Six Sigma DMAC approach, we have the define, measure, analyze, improve, and control phases of the project. In the define phase, we've defined the problem statement, our goals, objectives, scope. We have identified the key stakeholders. We've defined the project timeline. And I've also studied the existing process in the clinic by visiting the clinic, observing manually in person, and clarifying my doubts and questions with the staff members and the nursing team out there. So that's how I was able to define the current state process. In the measure stage, we have um, collected data. One is by manual observation, as well as from electronic health records, as well as by feedback. These are the three main ways that I collected the data. Analysis phase involved analyzing the collected data and identifying the challenges or the bottlenecks, identifying the root causes of the bottlenecks. And in the improve phase, I have proposed recommendations to improve the existing workflow, sat with this team to brainstorm ideas for the suggested improvements. And in the control phase is all about sustaining the implemented improvements and monitoring the key performance indicators. So let's begin with the define phase first, where I define the current or the existing process. The slide also shows where the bottlenecks have been. So the existing process begins with the patient's arrival in the clinic, and they have to undergo the check-in procedure, which involves verifying their demographic details, ensuring that the yearly consent forms are in place, the guarantor and the insurance details are in place, and they're up to date. And any other additional visit specific and age specific forms like anxiety, depression, the school physicals, the sports physicals, and several other age-specific forms that are given to the patients at the time of check-in. The forms are usually given with their patient name labels printed and affixed to the forms. So this would complete the check-in process. And this is the rooming process. Once the check-in is completed, the patient's name will appear on the arrival list. As soon as the patient's name appears on the arrival list, one of the medical assistants will take over the patient. And as soon as that happens, the patient's name will disappear from the arrival list. Once the patient has been taken up by the CMA would activate the rooming indicator in Epic. We'll start with all the preliminary documentation and preparation, which is going over the reason for their visit, any pre-orders, because they also have standing orders that they can do, any pre-visit documents or any documents that they need to collect from the patient for the visit. They would collect it. Billing, if there's any preliminary charge information that they need to put in, they would go over that as well. And then once all of that is ready, and once they ready the room, then the CMA would call the patient in for rooming and escort the patient inside, do their vitals, check their height, weight, take them to the room for doing further assessments like the vitals and going over some of the screening assessments and going over a little bit of their history. And once the CMA documents all of the findings into the epic, the CMA will change the indicator in the epic, uh, indicating that the patient is ready for a provider evaluation, or the patient is ready for immunization or for further testing. And then the CMA will log out of Epic and come out of the room. But as the CMA walks out of the room, there's a flag system outside the room, and they will put the appropriate flag to indicate who is the next person to enter. They also have a flags like the colors that are specific to every provider. So looking at the color of the flag outside the room, a person would know whether a nurse is to enter, or a specific provider is to enter, or a CMA is to enter, or if the patient is done with the visit. So with here is the end of the rooming process. Now we have the consultation. So once the rooming is done, the CMA is out of the room, the consultant would enter the room to go over the patient. And I, because of HIPAA reasons, did not enter inside the room and was not present at the time of consultation inside the patient room. I would be waiting outside doing my observations. But once the consultation is done, the consultant exits the room, prints the after visit summary, gives the after visit summary to the patients, telling them that they're ready to go. And while they're walking out of their rooms, they would go to the front desk and get any follow-up appointments scheduled if indicated by a provider. Once that is done, the patient is done with the visit and the patient exits the clinic. So this is the current state process that I studied in detail. And now coming to the analysis phase. So all of the data that I collected, I realized that I collected way more data than was required. So I sorted the data out. Whatever data I required, I got it to the form that I had to use it. And for the complete data analysis, I used just the advanced Excel functions. So this is a sample of how I presented my analysis, and this is for the check-in. However, I did analyze and presented similar data for every step, from check-in wait time, check-in duration, rooming wait time, rooming duration, consultation wait time, total consultation duration. So for every step of the process, I have presented such an analysis, but here is an example to present it. So I've indicated the sample size, the average time in minutes that would take for the procedure, the standard deviation, the shortest observed duration, the maximum observed duration. For example, wait time to be attended by front desk staff. It is nothing but the time from the patient's arrival in the clinic to when they are attended by a front desk staff. So this shows that for a sample size of 105, on an average, patients waited about 0.29 minutes to be attended by a front desk staff, with a standard deviation of 0.84 minutes. The shortest observed wait time has been less than a minute, and the longest observed wait time has been a maximum of 3 minutes. Similarly, we have check-in duration. That is the amount of time taken to check in the patients from their arrival to complete the check-in. And this I have mentioned here per electronic health record and the actual check-in duration, because I've observed that as soon as the patients arrive in the clinic, the staff members try to check in the patients as quickly as possible so the rooming staff can get started with the rooming procedures. However, even after they're checked in per the electronic health records, the patients are still at the front desk with the staff completing their formalities. So actual check-in duration represents the actual time that the patients have been with the front desk staff completing all of their check-in formalities. So if we see for the electronic health record, on an average, it takes about 1.05 minutes to check in the patient. Whereas the actual check-in duration, actually, they take about on an average 2.3 minutes to check in the patient. So this was a very significant point to look into. Also, actually, we have observed that the maximum time to check in a patient has gone even up to about 9 minutes. Whereas per the electronic health record, the maximum that's documented is up to about 4 minutes. So analyze, this is a rooming wait time sample. So for every data or the analysis that I presented, like the last previous slide, I also gave visual representation of the data, and this is an example of that. For example, for the rooming wait time analysis, I have provided a visual representation of, on an average, like they take about 6.6 minutes um, to be called by a CMA for rooming with a standard deviation of 3.1. The minimum observed is 1 minute, and the maximum observed rooming wait time has been about 19 minutes. And here, what is significant to us is the ones in orange, which indicate the wait time of more than 10 minutes. Because up to about 10 minutes, the patients are usually okay to wait. But when it exceeds 10 minutes, the patients get a little bit anxious, a little bit frustrated. So here we tracked back to those cases to see what really caused the increased wait time. And that is why the ones in orange that I've highlighted for every step, check-in, rooming, as well as consultation, have been areas of concern. And this is again a total consultation duration visualization. So here the darker yellow represents the amount of time a consultant spent with the patient, and the lighter yellow represents the additional time the patients were in the room after the consultant exited. And the entire bar represents the total consultation duration, that is the total amount of time patients spent in the room after the completion of their rooming from the time they saw the consultant. And this also I have divided for the appointment schedules, like for a 60-minute appointment, on an average, a consultant spends 32.1 minutes with the patient. And once they exit, the patient is still in the room for 4.2 minutes. For a 30-minute appointment, on an average, patients spend 19.8 minutes with the consultant and 4.2 minutes in additional time after the consultant exits. For a 15-minute appointment, patients have spent about 16.7 minutes with the provider and 1.2 minutes of an additional time in the room after the provider exits. Now, this is important because the amount of time they occupy the room, that room is unavailable for us to use for the next patient. So that is another area of concern for us to look into. And this is how I represented the root cause analysis in the form of a fishbone diagram. And this is a sample where I've highlighted some of the most significant causes that we've come across. But I did this for every step of the process, for check-in, for rooming, for consultation, providing detailed root cause analysis for every step. So this is just a demo of this is just a demo highlighting some of the important causes throughout the process and not just in any one step. So one of the most important that I came across was guarantor account setup, which takes a long time because if that is not set up prior to the patient's visit, Then the front desk staff members have to collect the details. They have to send for query, wait for verification. Unless they wait for verification and verify those details, they cannot go ahead and get started with the visit. The second one is lengthy screenings, which is one of the problems the CMAs faced, because some of the screening assessments have very lengthy questionnaires, and that significantly increases the time taken for rooming. Pending referrals, definitely there are a lot of pending referrals, like significant numbers, and the staff members have been working on it in addition to their normal workload or normal assigned responsibilities. So they have been multitasking, they have been juggling several things, and it becomes particularly overwhelming for them to keep a track of patient when they're working on multiple things, and it does affect the quality of the service. Visit specific paperwork, definitely once the patients are checked in after verifying their demographics and consents, patients still spend time with the front desk staff. That means the front desk staff are still tied up to the patient because they're giving them paperwork, physical paperwork, printing out the name labels, affixing it to the paperwork, giving it to the patients. So that is taking more time. And this is all the time that if we can try to save, it can be used to see more patients. Lack of end of visit protocols was very significant because I did observe that because of lack of end of visit protocols, some patients remained in the room for a significant amount of time because they did not know that the visit was over and that they were ready to leave the room. Immunization delay, yes. The immunization at the clinic, I did observe that it is taking a little bit longer than the usual. And one of the causes has been the barcode scanner malfunction that increases the documentation duration as well for immunizations. So that is a process that we had to study a little bit more in depth. But this is how I presented the root cause analysis for every step of the process. This is a sample of the recommendations that I provided, that I have provided for the consultation aspect of the process. But I have provided such recommendations for every step of the process, from check-in, rooming, and consultation. So with regard to consultation, and with regard to some of the identified root causes for the increased consultation duration, I provided recommendations to lessen the duration for vaccination. That is by looking into fixing the barcode scanner, by having grab and go kits for the nursing staff. And one of the other things was if the provider is able to alert the nursing staff early on in the visit that the patient is ready for vaccination, then it can help the nursing staff to start working on preparing the vaccine. So that workflow coordination is also something I emphasized on. For lab withdrawals, we could have a designated phlebotomy station. We could train the CMAs more on the pediatric lab withdrawal challenges and how to handle them. And most importantly, it is very essential to inform all the staff where we are right now, what the set benchmark is, and what we plan to achieve. So that's the goal that we would like to set it up, and we would like to inform the medical staff about it as well. Then we have the medical students. So when the medical students interacted with the patients, they took about around 18 minutes longer. So either we could set a time limit for the medical students, or we could have the consultant enter the room along with the student to save time, but I'm not sure how conducive that would be for a student's learning, because this is primarily a learning center. If that is not conducive for their learning, we can also think about designating certain days for students where we can adjust the clinic schedules to accommodate lesser patients on those days and accommodate relatively more patients on the other days. And patient dismissal, we have to emphasize and encourage time and again about the lack of end of visit protocols for our providers as well as for our CMAs. Virtual providers, the staff members have to ensure that the connection is in place, they are talking to one another before they exit the room. EHR documentation, the staff members were encouraged to follow the process in the right order. Like if step one is checking, step two is rooming, then we have to complete step one and then move to step two. If we move from step one to step two back to step one, the data is not accurately documented in EHR. So though there is data in EHR, we are unable to use it for our quality improvement purposes, because it is not, the process has not taken place in the right order. So I did emphasize the right documentation in the EHR, which would help us to perform such quality improvement analysis with much ease and with much more accuracy and with much more larger sample if we were able to use that data. Interpreter services, we have to definitely ensure that we have quicker connection for all languages available. And that is something that we need to check with the service providers and let them know and give them feedback time and again. So these are some of the recommendations just for the consultations, but I have given such proposed recommendations for check-in, for rooming, and for consultation. Finally, the practicum reflection and readiness for my next steps. So definitely with this quality improvement project, I feel like I'm very prepared for the next step in healthcare administration and leadership. I have definitely gained a practical experience leading a quality improvement project at an outpatient clinic. It has definitely strengthened my skills in communication and teamwork. I have applied the concepts that I've learned in the course. I've collaborated across various teams and I've navigated the challenges in the real world clinical setting to drive the clinical and operational improvements. So on the whole, like it has definitely helped me develop more confidence in data-driven approaches to decision making and leadership abilities. Overall, the practicum has provided a very strong foundation for advancing into future healthcare administration roles. Thank you.